I diagnosed my first EDS patient in 1990 and operated on her multiple times, and she did fine, so I never learned the lesson that EDS patients don't do well with surgery. My partner is well versed in this area and also operates on the lower extremity. I have reasonable credentials to discuss this with 11 years of training and about 30 years in practice, and have no conflict of interest. My success in the EDS patient population led me to be invited to write this journal article, which went out internationally in 2017. And I gave a talk on today's topic at a previous Global Learning Conference in 2022, and during that talk, one of the people in the audience called my office and made an appointment to see me, and eventually came to Seattle and had surgery on his upper extremities by me and his lower extremities by my partner. He goes by the name Kinda Spoony on TikTok, and about a month ago, he posted his journey with my partner and me online. And I am too old and too uncool to be on TikTok, but my patient's post has had about 80,000 hits in just 1 month. My partner and I see so many patients with hypermobility issues that we were invited to contribute to this book that came out last December, and we authored or co-authored 8 chapters. We know what is going on with these patients where looks can be deceiving, and we've been able to figure out what hurts and why. In the upper extremity, hypermobile patients as a group tend to have a complex but predictable pattern of upper extremity problems with 3 general reasons to seek medical attention. The first is pain. Unfortunately, the pain is activity-related and not necessarily symptomatic in the doctor's office, and it can vary in intensity as well as location. Vague intermittent pain is about the last thing an orthopedic doctor wants to see, and it often causes doctors to start ordering tests. The weakness in the hands is a universal complaint for hypomobile patients, but it's an odd weakness. Dropping things, can't open prescription pill bottles or anything in the kitchen. Carrying luggage isn't a problem. If you exercise your hands to make them stronger, ironically, they become weaker. Numbness is a very common problem, and the whole hand can go numb at night, and during the day, the ulnar 3 digits tend to go numb. Nerve tests, which are painful and expensive, are often performed multiple times and are normal, even though the complaints for which they're being ordered are clearly nerve-related. Patients get told that it's not carpal tunnel syndrome, and older patients get sent to spine surgeons as neck x-rays and MRI are rarely normal. Unfortunately, none of the tests explain the hand or arm symptoms, and patients are left hanging, rejected by the hand surgeon and the spine surgeon. It's not the patient's fault. There are 4 general causes of these complaints, which can be identified and addressed and disambiguated if the provider is knowledgeable and patient. Peripheral nerve compression in the upper extremity is a problem in 100% of hypermobile patients, in particular the median nerve at the elbow. Patients have symptoms where the nerve ends, not where it's compressed, and this often confuses people, first the patient and then the doctor. The doctor has to know a lot of detailed nerve anatomy to figure this out. Joint instability is a universal problem for Ehlers-Danlos patients, and the difference between loose and sore can be one fall on a flat, hard surface. Unfortunately, the teaching of the physical exam findings for joint instability is inconsistent across the medical profession and typically poor. Tendon problems fall into 2 categories, inflammation and subluxation. Tendinitis in this patient population is overdiagnosed but treatable when correct. And subluxation, meaning partial dislocation, if it's not painful, can be ignored. When patients have pain in the hand or arm of sufficient severity and duration that affects their quality of life, eventually their posture becomes an issue, and this tends to magnify nerve problems as well as swelling. None of these problems show on standard diagnostic tests, and again, not the patient's problem or fault. These problems of the upper extremity can be diagnosed and treated successfully in carefully selected patients where the diagnoses are clear and the doctor knows about procedures that are available and understands the patient's needs and expectations. Here's a simple physical exam finding that anyone can perform. If you can do this with someone's index finger knuckle joint and they're trying to have a life, it's extremely likely that they'll have a distinct pattern of upper extremity problems that I'm about to describe. If you're loose-jointed, stubborn, and pain-tolerant, and trying to have a life, meaning spouse, children, job, household, hobbies, big problem. I started working on a protocol for assessing hypermobile patients with vague upper extremity complaints in about 2004. And the gist of this is to look at the whole person and figure out where the points of friction are and try modifying their activities rather than their arm. By the time we see someone, they've usually modified their activities to the extent they're able to and are still in pain. And we try to fix whatever is painful. We use this template starting in 2004, which gets updated periodically as we learn more from our patients, and it can be downloaded from our website. This shows the skeptical woman with the arm that's killing her, who looks fine, who has also often been told there's nothing wrong. Once we have a feel for the patient's circumstances and what they'd like to be doing versus what they're able to do, we go down the arm using this template. The cervical spine, as a minimum, is stiff and straight and sore. Like Ehlers-Danlos Syndrome, most doctors don't know anything about the thoracic outlet. The thoracic outlet is where the nerves and artery enter the arm and the vein exits. Tension or compression in this area can cause vague arm complaints of pain, weakness, fatigue, or numbness, with no symptoms at the outlet itself. Like Ehlers-Danlos Syndrome, proximal median nerve entrapment is rarely, if ever, diagnosed. However, it is a universal problem for all Ehlers-Danlos patients. It causes people to drop things and unable to open things in the kitchen. It also causes intermittent pain in the wrist, frequently misdiagnosed as tendinitis. Real-tunnel syndrome is an almost universal problem for Ehlers-Danlos patients. This would be aching pain on the outside of the forearm, sometimes referred to as tennis elbow. It tends to be treated as a nerve problem, but it's really mostly a tendon problem, which is why the nerve tests are normal. Painfulness with the wrist is an almost universal problem for hypermobile patients who often fall because their ankles are unstable. No pain at rest, but push-ups are painful or impossible. The ligaments are physically intact but mechanically stretched, so x-rays and MRI would be normal. And my colleagues as a group have a hard time ignoring normal tests, particularly when evaluating a patient with vague, intermittent, variable pain. Painfulness with thumb is a universal problem for Ehlers-Danlos patients. The joint starts out loose and then subluxes related to altered pinch mechanics caused by proximal median nerve entrapment. It's frequently missed or misdiagnosed or treated with exercise or steroid injections, which both tend to make it worse. Tendon subluxation is common, and surgery would be necessary for stabilization. Chronic hand, wrist, or arm pain often affect posture, magnifying cervical spine or thoracic outlet issues, and this needs to be addressed as part of the treatment for arm complaints in hypermobile patients. It would be so helpful if doctors and patients knew more about Ehlers-Danlos syndrome and what treatment options are available, but without that knowledge, many of my colleagues resort to a simple answer, which is depression. Many of my patients have seen multiple providers before me with many tests and no diagnosis or treatment plan. The doctor's implication, either directly or indirectly, is that the patient is the problem, not the arm, that they need a psychiatrist, not a surgeon. And this pattern of gaslighting and denial is so common that I've invented an avatar to represent these doctors collectively, and I've named the condescending, arrogant Dr. Umwelt Phlogiston. These doctors seem to be physically incapable of understanding the patient's experience and completely attribute the somatic complaints to underlying depression based on their lack of knowledge and the overwhelming number of vague intermittent complaints in the face of normal tests. The patient is the problem, not the arm. This can have disastrous consequences, such as in New Zealand last year when doctors dismissed the complaints of patients with known Ehlers-Danlos syndrome, resulting in the deaths of 3 women. The patients are blamed for the failure to cope. In my opinion, these doctors sort of have it backwards. The symptoms clearly aggravate pre-existing depression. And when they deny the basis of the patient's arm symptoms, they can be, in the words of someone famous, casually cruel in the name of being honest. If you find yourself in this type of situation, my advice is to try not to take it personally and to move on. All doctors don't know everything, and finding knowledgeable providers can be difficult. You need to find the right partnership with a provider, and blame has no place in an exam room. If you're feeling blamed, you have the power to ignore this criticism and be a strong advocate for yourself, and be more discerning when picking providers. My partner and I operate on 2 to 4 EDS patients per week, and they have helped us figure out what works. Once we have a feel for the patient's circumstances and what they'd like to be doing versus what they're able to do, we go down the arm using this template. I give patients homework assignments with online resources to educate themselves, and I also order whatever imaging or testing might be necessary. The cervical spine joints are loose, but the muscles are tight, often in spasm. The neck wears out prematurely in hypermobile patients, and this MRI shows bulging discs, which can cause nerve root compression, which can cause radicular symptoms in the arm. This is what the nerve roots look like coming out of the neck and entering the arm. C6 is the most common nerve root to cause referred pain in the arm, and patients with thumb arthritis often have neck arthritis around the same time for the same underlying reasons. C6 radiculopathy can cause overlapping aching pain in the region of the thumb, which can easily confuse the patients and their doctors. We address the thoracic outlet as a cause of vague arm complaints. The thoracic outlet is between the anterior and middle scalene muscles, and it's crowded there, subject to both tension and compression. With good posture, there's no tension or compression on the nerves as they exit the neck. With forward head and sloped shoulders, a common posture in patients with chronic hand, wrist, or arm pain, and in patients suffering from depression, the nerves may have to bend up to 90 degrees, and if kept in that position, they stop working. And it hurts where they end, not where they're compressed, causing vague aching pain in the arms. When the posture is poor, the scapula eventually protract, and the suprascapular nerve goes with this scapula, and it gets stretched, which weakens it. The suprascapular nerve innervates the supraspinatus and infraspinous muscles, which are external rotators of the rotator cuff. This stretching of the nerve weakens these external rotators, causing an imbalance that makes the shoulder rotate in and down, making it harder to maintain posture, like you were in a rowboat and your oars fell off. To check this, we test the supraspinatus muscle, which is responsible for the first 30 degrees of arm abduction. This patient is post-op from the so-called Ericson Special on the right and has consistently good posture bilaterally, and this video demonstrates normal supraspinatus muscle strength. This hypermobile patient has chronic hand, wrist, and arm pain and is pre-op and has been unable to maintain her posture, and this demonstrates bilateral supraspinatus muscle weakness. This hypermobile patient is about 3 months post-op on the right from the Ericson Special and pre-op on her left. Just by making her right hand and arm strong with pain relief, she's been able to maintain her posture on the right side, and the suprascapular nerve recovers. Proximal median nerve entrapment was described incorrectly in the 50s and then more incorrectly by somebody more famous in the 60s, and then just repeated. So there are decades of books where this is described incorrectly and therefore, like Ehlers-Danlos Syndrome, not diagnosed. The nerve gets pinched at the elbow with a gradient of pressure that affects the anterior interosseous branch of the median nerve, which causes weakness of pinch and intermittent wrist pain. This video demonstrates the weakness of the proximal median nerve entrapment and how the strength of the muscles innervated by the anterior interosseous nerve is restored in the recovery room immediately and permanently. The nerve tests are not helpful for this, with a 97% false negative in my experience. So here's the FDP of the index finger strength. If you could hear the soundtrack, you would hear the EKG monitor, and you can see the betadine. But I'm pulling as hard as I can, and I cannot straighten this finger out, and the thumb comes back at the same time. The anterior interosseous nerve has a sensory branch that goes to the wrist bones, unfortunately, the bones of the carpal tunnel, and it's easily mistaken for carpal tunnel syndrome or misdiagnosed as severe tendonitis. There are 7 areas around the elbow that can compress the median nerve, and the lacertus fibrosus is one of them. It's a tight band that pushes the pronator into the median nerve. This can be cut without consequence. The deep fascia of the ulnar origin of the pronator is the real culprit, and it can be cut also without consequence. This is what the fascial band pressing on the median nerve looks like in the operating room about 3/4 of the time. And this is what the nerve looks like after that fascial band is cut. And this is what the scar looks like in the operating room these days. This is a patient 5 weeks post-op on the right and 4 months post-op on the left. There are 4 general ways people adapt to the weakness of the anterior interosseous nerve, and the adaptations occur spontaneously without conscious effort or necessarily even conscious awareness. You can use the next muscle down, which is a different nerve. You can pinch sideways on the thumb using ligaments to give resistance. You can pinch sideways on the index finger using ligaments to give resistance. Or you can pull the wrist up, tightening the flexors, giving tension. The weakness of the anterior interosseous nerve turns out to be proportional to joint laxity, and what wears out depends on how discreetly one adapts to this weakness. And hypermobile patients, particularly Ehlers-Danlos Syndrome, are so weak they have to use all the adaptations and everything wears out. The flow chart shows the motor and sensory consequences of proximal median nerve entrapment. The motor consequences of the anterior interosseous nerve weakness are shown at the bottom with the 4 general ways of adaptation. The things in the black box can be painful, and the things in the gray box tend to show on X-ray. The sensory consequence of proximal median nerve entrapment demonstrates pain where the nerve ends, not where it's pinched. Worse with sustained pronation, such as mouse, keyboard, knitting, motorcycle riding, windsurfing. Patients who are hypermobile who adapt to AIN weakness by wrist extension get Ehlers-Danlos Syndrome. They get hypertrophy of the wrist extensors, which rips the fascia that connects the muscles to the bone. And when the fascia rips, it swells, and when it swells, it aches. And there are stretch receptors that send a pain signal to the brain, and this is why massage works in this area. This patient is surgery for Ehlers-Danlos Syndrome by somebody famous in Seattle who treated it as a nerve problem. It didn't work, and she came to me off work and on narcotics and was told she was a bad healer. Treated as a nerve problem, this leaves a big ugly scar with about a 30% success rate. This is my scar from redoing her surgery, treating it as a tendon problem, off narcotics and back to work full duty 2 weeks post-op. The hypertrophy of the extensor causes a tendinosis of the fascia that connects them to the elbow. And if you cut the fascia that's ripped and decompress the radial nerve at the same time, probably 95% of patients have 95% relief of pain in this area. And you can decompress the anterior interosseous nerve through the same incision at the same time through a 1-inch anterior incision, and it takes about 20 minutes with no cast or splint or therapy. Painful mechanical instability of the wrist is very common in Ehlers-Danlos Syndrome patients. This is what the scaphoid shift test looks like. And if this is painful and reproduces the patient's dorsal wrist pain, this can be stabilized surgically. This is what the scars look like after surgery. The pisiform is a small bone within the FCR tendon, and it is supposed to be here, but in most Ehlers-Danlos patients, it's here. And if going back and forth is painful, that bone can be removed like this. And this is what the scars look like for this particular procedure. The distal radial ulnar joint can also be painful and unstable, and there are several ways of stabilizing that. Thumb instability is a universal problem in Ehlers-Danlos Syndrome patients. The thumb is here, and it's supposed to be here. And if it's painful when it goes back and forth, or if the x-ray looks like this, it can be fixed with an operation that was invented in the 60s and published in 1973 that's like the ACL repair for the knee, and it works even in Ehlers-Danlos patients. And this is what the scars look like. Tendon subluxation is common and can be painful. Here's a thumb pre-op on the patient's left and post-op on their right. You can see the tendon subluxation, and also note that the joint has global laxity. This is post-op, and you can see the tendon is where it's supposed to be, and as an incidental benefit, the joint becomes much more stable. Tendon subluxation can be painful or just cause locking of the fingers, which can be quite annoying, and there's no non-surgical treatment for this. This is what the scars look like to fix the tendons. The so-called Ericson Special would be to address at one setting all the painful tendon, nerve, or joint problems distal to the elbow that can be fixed. This would be a typical operative note, which would involve 8 to 12 procedures simultaneously. This patient is post-op on their right and pre-op on their left, and these are the typical scars to the Ericson Special. And this is thumb CMC joint instability. This would be painful instability of the pisiform. This would be mechanical instability of the wrist. And this would be weakness associated with proximal median nerve entrapment. She's pulling down as hard as she can. And the thumb is also weak. Post-op, in the recovery room, normal strength of the thumb, and the joint stability is restored. Patients with residual arm symptoms after the surgery tend to have thoracic outlet issues or cervical spine issues, so it's important to address those problems prior to surgery on the arm. And it's most important to actually listen to the patient and understand their unique needs and expectations.